Yay. Hello, everybody. Oh my God, we're so on time. I love it. I'm very proud of us. This is our first official session of the conference. I'm really, really excited to welcome Dr. Dovey and Caroline from Spring Fertility, who are going to walk us through really kind of like a thorough overview of the different options for family building in a fertility clinic setting. We'll talk a lot about people choosing or growing their families with donor sperm, but we're going to cover, they are going to cover a lot of different things. I encourage you, we will have time in the end for questions. So if you have specific questions, please try to keep them into the Q&A, and then feel free to chat and share reflections or anything that you want in the chat area. So it is my pleasure to introduce Dr. Serena Dovey, who is a board certified reproductive endocrinologist and infertility specialist. She attended medical school at the University of Virginia and then completed her obstetrics and gynecology residency through Harvard Medical School at the Beth Israel Deaconess Medical Center. Dr. Dovey went on to complete her fellowship in reproductive endocrinology and infertility at the University of Pittsburgh Medical Center, McGee Women's Hospital. Dr. Dovey's decision to join Spring was driven by her dedication to achieving the best possible clinical outcomes while maintaining the highest caliber of patient experience. And then we have Caroline McCrae, who joined Spring Fertility as a genetic counselor. As an undergraduate student at Wilfrid Laurier University in Ontario, Caroline majored in biology and psychology with a minor in chemistry. She then completed a master's degree in human genetics at Sarah Lawrence College. And I'm so glad that we have both of you because I often get questions about genetic screening and all of the options. So thank you for being here and take it away.
All right. Thank you so much for that introduction. That was great. Let me just pull up the slides here and share those. Give me 1 second. Like this is always the part that takes me a second to get ready. Okay. Actually, hold on. I'm gonna put these here. Okay. Okay. And then I'm gonna start the slideshow. Okay, can you guys see my slides okay here? Okay, perfect. Sorry, that part always takes me a second to get it all situated. All right, well, yeah, thank you for having me today. As Maria said, I'm Dr. Serena Dovey. I'm a fertility specialist here at Spring Fertility. I have been here since 2020 and work primarily out of the East Bay location. So it's great to have you all here today. And basically, we're just going to talk a bit about what sort of family building options we can offer here in the setting of being in a fertility practice. So again, this is just myself and Caroline who are going to speak today. Okay, so just to kind of start at the beginning, there's obviously three kind of ingredients we need to make a baby. We need a healthy egg, a healthy sperm, and ultimately a place where once the egg and sperm create an embryo, a place for that embryo to grow, aka, a healthy uterus. Maybe someday we'll have artificial wombs that can gestate children outside. But for now, we need a healthy uterus. So, okay. And so depending on, your family makeup, your partner, whether you may be trying to pursue having a family on your own, sometimes this may require working with an egg donor or a sperm donor or a gestational carrier. So a variety of things, a variety of options we can that we work with to help families of all shapes and sizes, have the family that they want or have the children that they want. I'm going to primarily focus on building a family with a sperm donor today, but we will have a lot of time, I think, for any questions and answers. So please feel free to ask me anything. And also throughout the talk, I'm happy to answer questions as we go along. So please don't hesitate to kind of reach out in the Q&A, and we can pause and answer any questions as we go. So, but a lot of people are just curious about, like, if when we first start to look at family building, I think sometimes it can feel a little intimidating. And so this, just wanted to kind of talk through, if you come in and meet with us, kind of what that initial conversation may look like. So a good first step is just to schedule a consultation so we can start to talk about what your specific fertility journey may look like and what we may need to help build the family that you want. So we see patients here both in person and also virtually, so we can try to be flexible. And then one of the first conversations I like to have with patients is just, what are their family planning goals? Some people may be looking to have one child now. Some people may be looking to have 3 children and not be kind of ready to start a family for a few years. So just trying to identify the number of kids that you may want and the time frame that you may want to have those children, child or children, can help kind of direct like where we would go next. The next question we'll often ask is, for someone who may be in a relationship with someone who has eggs or doesn't produce sperm, or somebody who may be single and trying to have a family on their own with a sperm donor. We will kind of identify what sperm sources may be, or talk about the sperm source that you're thinking about in terms of starting to build a family. And so we'll talk a bit about basically the 2 main sperm options, or either to use what's called a directed sperm donor, and that's basically somebody that somebody, some of my patients may choose to use like a close friend of theirs. Sometimes people may choose to use like a brother of their partner, because that if you have a partner, who produces eggs, they may have the brother shares 50% of their DNA. And so sometimes they like to use family members like that as a donor. So a directed donor is basically just someone that is known to you and is going to act as your sperm donor. And that's sort of contrasted with a non-identified sperm donor, which is basically purchasing sperm from a sperm bank. And we'll talk a little bit about that process as well. And then sometimes there may be a scenario for people who don't produce eggs that we may need to use an egg source. And so there can be both similar options, really. Directed egg donation, you may use somebody who know to donate eggs to you and go through a round of IVF to retrieve those eggs. That's considered a fresh donation cycle, or there's also agencies that help identify egg donors that can provide eggs through a fresh cycle, or because we're able nowadays to freeze eggs, kind of very similar to how we freeze sperm. Egg freezing has not always 15, 20 years ago, we're not as good at egg freezing as we are now. But nowadays it's a very reliable technology. And so just like there's sperm banks around the country, we now have egg banks too. And so for people who may be looking to utilize an egg donor to build a family, there are egg banks that you can purchase eggs from and create embryos to create a family that way. So, and then finally, again, like I mentioned, one important thing is timing. You're always interested in whether you're looking to have a family today or potentially looking to have a family in the future. For people who produce eggs, the age of the egg is a strong determinant of fertility overall and the quality of the egg. And so for people who may be looking to delay having a family for a bit, sometimes looking at freezing eggs or freezing embryos would be an appropriate thing to talk about until you're ready to start a family. So. Okay, so I'm going to kind of focus a little bit here now on the different ways that we might utilize donor sperm to create families, and different sort of things to think about, different triage points that we get to. So again, as I mentioned with the last slide, questions we'll kind of talk about at this initial visit are, how many kids do you want to have? What sperm source might we use? from working with a patient or a couple who, both produce eggs and need to identify a sperm source, or, do we need to look at having the egg source sometimes for patients who don't produce eggs, or sometimes for people who who produce eggs but are kind of at an older age where their egg quality may not be so good, may also require looking at an egg donor. So we'll talk about that. And then also, we'll basically talk about who's going to be the gestational carrier, who will gestate the embryo that we're planning to create. Okay, so first I'm just going to talk a little bit about when you're in the process of deciding if you're going to use a sperm donor to have a family, a little bit about how we use both directed or how basically screen in a fertility setting, directed sperm donors, and also utilization of non-identified sperm sources, which typically would be purchasing sperm from a sperm bank. After that, I'll talk a little bit about what we can do with donor sperm. Typically, we have the option of either doing intrauterine inseminations versus IVF, and we'll talk a little bit about how do we decide which route we might use. Should we use medication or not medication? So I'll go through a little bit of that decision-making process as well. And then we'll talk a little bit about IVF, and when scenarios we might look at doing IVF over doing IUIs. And then again, the timing part of it. I think it's helpful to understand that, when you want to become a parent determines when you should start the process. And if you're looking to try to have a family soon, it often can take somewhere between 12 to 24 months from this initial visit that we'd have to the moment you may be holding your child for the first time. So it's sometimes helpful to kind of think about that time frame and the age you may want to be, when you actually are looking to have that first child. Okay, so I'm gonna first just talk a little bit about using sperm from a sperm bank or a non-identified donor. So there are a variety of sperm banks in the United States, and they basically will recruit sperm donors. And sperm donation is something that the Federal Drug Administration, the FDA, regulates. And so there's regulated testing that needs to be done on people who act as sperm donors. So there's for when someone's going to be a sperm donor at a sperm bank, basically there's health questionnaires that are filled out, family history that is looked at. Obviously, semen analysis is done to ensure that the sperm parameters in terms of count, motility, shape are all normal. There's genetic screening, and I won't go too much into that because Caroline's going to talk a bit about the genetic testing we do for sperm donors and egg donors, and also patients who are looking to start a family. And then basically the FDA regulates the infectious disease testing of sperm donors to help mitigate the risk of ever being exposed to any sort of infectious disease through donor sperm. So in the setting of a non-identified, using a non-identified sperm donor from a sperm bank, what the FDA regulates is they require FDA testing at the onset, which is a questionnaire that people would fill out, an exam, and then blood testing to look for a variety of infectious diseases. And then the sperm is actually frozen and quarantined, and then the donor needs to come back again at 6 months and redo the testing before that sperm is released to be purchased. So any sperm you might purchase from a sperm bank has already gone through this regulated 6-month quarantine from the bank. And then there's also some recommendations from the American Society of Reproductive Medicine in terms of conceiving using a sperm donor. Again, they do recommend typically doing genetic carrier screening so we can kind of assess whether there could be any specific genetic risk to a child from the person whose eggs we're utilizing and the sperm donor we're utilizing, to make sure that there's not a sort of a genetic match where there's a risk of having a child with a specific genetic disease. And for people who are looking at choosing a donor through a sperm bank, when you're looking at the different donors, you'll find that they've generally gone through some level of genetic carrier screening that you'd want to match with your own testing that we would perform here. And then we also, the American Society of Reproductive Medicine also typically recommends meeting with a reproductive psychologist, just to kind of talk about, choosing a sperm donor, different types of donation, ages of children, and at which point developmentally they ask questions about, how they were conceived. And there's, unlike 15 or 20 years ago, there's so much more research now, and there's a lot of educational resources. And so the goal of that counseling session is really just to kind of further educate about the resources that are out there, and also about the studies that are now, have been done on like psychological health of donor conceived children. So that's kind of the idea behind that. If you're looking to use an identified sperm donor, then typically for patients who are here at Spring, typically that we would actually have the donor come and do testing. And again, the FDA does regulate this testing, but so the different steps we would do to sort of screen a potential known sperm donor, identified sperm donor. Again, typically there's like a medical questionnaire we'd want them to fill out to make sure there's no specific medical contraindications to using their sperm to create a pregnancy. Usually family history, like to look at semen analysis would be done to ensure appropriate sperm production, that genetic carrier screening that I mentioned. And then if everything is lining up and all the screening tests are looking good, then typically, again, we would have the identified donor plus the intended parents meet with one of our reproductive therapists just to talk about the arrangements, kind of make sure everyone's on the same page about what the relationship may be with that future child. And then ultimately, for someone who's going to act as an identified or known donor, we would want the intended parent or parents and the donor to have legal contracts in place that just really clearly specify, intention for parenthood versus donation. So ultimately, once we've done all that screening on a known or an identified donor, then we would bring the donor in to do FDA testing, which again just involves doing blood work, a questionnaire, and a physical exam. The one difference between using an unidentified donor from a bank versus an identified donor is that the FDA doesn't regulate having to have a 6-month quarantine if you're using an identified donor. And so we don't typically need to quarantine the sperm and then bring the donor back again in 6 months to retest. But anyways, that's a lot of in the weeds about how we would potentially screen a sperm donor if you're interested in utilizing a sperm donor to start your family. Once we've identified the donor, then there's basically 2 main treatment options we can do to help someone conceive who's using a sperm donor. Typically, that involves either doing an intrauterine insemination or IVF. And which route we go really does depend a lot. Sometimes it depends on a variety of situations, and I'm going to talk through some of those. But one of the most important prognostic factors really is the age of the egg when we're creating a pregnancy. For people who produce eggs, basically, we're born with a finite number, and both the number and the quality of eggs declines as we age. This graph is basically demonstrating what the overall chance of a pregnancy would be based on age at the bottom, again, of someone producing eggs, if that egg is sort of exposed to sperm on a consistent basis. And so you can see that, in the 20s, egg quality is typically best, and it's kind of slowly decreasing as we age. And so a lot of times, whether we do 6 rounds of IUI versus potentially go to IVF more quickly is oftentimes guided a lot by age, because as you can see, if you are somebody who's 41 or 42 and interested in starting a family, the chance of getting pregnant with IUI is going to be lower than it would have been like at a younger age. And so that's something that we like to just take into the equation. So assuming that someone is going to use a sperm donor to do inseminations with, there's a couple different options in this scenario too. So the simplest thing we often do is with just basically timing doing an intrauterine insemination with natural ovulation. And so this is basically just an intrauterine insemination being performed around the time of ovulation. So in a cycle like this, basically, we would have the person who's going to undergo insemination to try to get pregnant track their cycles, track for ovulation with an ovulation predictor kit. And then a procedure called an intrauterine insemination would be performed typically the day after a positive ovulation kit at home. Typically, once the ovulation predictor kit turns positive, typically the egg is released usually within about 36 to 48 hours. And so we like to get the sperm inside that following day. And the procedure to do an IUI is pretty straightforward. It's not that different than a pap smear. Basically, a speculum would be placed, and then the sperm that we would have already on site would be thawed that same day. We take a look at it microscopically to make sure the sample looks good and look at the motility. And then basically, with a very small catheter, place the sperm through the cervix and release it up inside the uterus. The other option when we're doing inseminations is sometimes we'll consider using medication to stimulate the ovaries a little bit. And these medications can sometimes make it more likely that you would release more than one egg. So the idea is that you might release 2 eggs with these oral medications. The most common ones that are used for fertility treatment are called Clomid or Letrozole. And one of the sort of decision-making points in terms of whether we would use a medication like this in conjunction with doing an insemination is often age. So for people who are under 35 and doing inseminations with a sperm donor to start a family. Studies have basically shown since the egg quality is still pretty good at that point, using the medication doesn't actually really improve the chance of getting pregnant. But because the point of these medicines is they sometimes will allow for the release of more than one egg, they actually do increase the risk of multiples. And so for somebody who is looking to conceive with a sperm donor through inseminations under the age of 35, I typically don't recommend medication because we're not really increasing the chance that it'll be successful, but I am increasing your chance of having twins. And typically, from a medical standpoint, we typically try to minimize the risk of twins because the twin pregnancy is associated with more complication and risk compared to a singleton pregnancy. On the flip side, though, for someone who might be looking to start a family via inseminations, who may be in their later 30s or early 40s, the studies in that scenario suggest that starting with the medication actually may improve the chance of getting pregnant through sperm donation. And so, again, it's looking at age is one of the primary things we look at in terms of whether I'd recommend starting with medication or not. Okay, what about IVF? So there's a variety of scenarios that we might choose to do IVF using a sperm donor. One is if there's a history of infertility already. So the way we often define infertility is if someone's been exposed to sperm for 12 months, 12 cycles of sperm exposure without a pregnancy, that's sort of the definition of infertility. So if you've tried to get pregnant in the past and it hasn't worked, this is a scenario, or done multiple inseminations and you haven't gotten pregnant, then oftentimes it leads up to IVF, which generally IVF for most people does improve the chance of getting pregnant compared to inseminations. Again, age factors into it. So sometimes for people who may be in their later 30s or early 40s, sometimes we might try inseminations for a more limited time, like 3 cycles, and then go to IVF if it's not successful, just because that fertility window, again, regarding the egg age, is a little bit more limited. I have many patients and who are also interested in something called reciprocal IVF. And what reciprocal IVF is, if there's 2 people who both produce eggs in a relationship and both really want to be involved, in the pregnancy experience, reciprocal IVF basically means that one person is going to undergo a stimulation of their ovaries and have the eggs retrieved. Again, we'd then create embryos with the donor that we've already chosen, the sperm donor, and then the partner would actually undergo what's called a frozen embryo transfer. We put the embryo created from the first partner into the uterus of the second partner, and that way one of them provided the egg source to create the embryo, and then the other one is gestating the child. And so that's what we call reciprocal IVF, and a lot of people are interested in doing that, so that both are involved in the creation of the child, which is always fun. Sometimes too, desire for the same sperm donor with additional children or embryo banking. Again, depending on the scenario, I will sometimes see patients who've already had one child with, let's say, a donor from a sperm bank, and they really want to have another child with the same donor, so they're full biologic siblings. But we only have sort of a limited amount of sperm left. And I should circle back and say that is something to think about if you're purchasing sperm from a sperm bank. One thing we really want to look at ahead of time is how many kids do we really want to plan for with this donor, because if you choose a donor, that you really like from a sperm bank, it's not a guarantee that same donor is going to have available sperm in 2 or 3 years if you're looking to have another child down the line. So we really always want to we encourage you to try to get as much sperm as you can to optimize having the family size you want. And one nice thing to know is that if you purchase sperm but you leave it at the sperm bank and you end up not needing all the sperm that you purchased, they often will actually buy it back from you at a later date. So but sometimes we do get in a situation where we only have a couple of vials of sperm left and a couple really wants a second, child with that same donor they used in the past. That's another scenario. Since IVF gives a better odds for pregnancy, typically sometimes we'll go to IVF if we have a limited amount of sperm remaining. And then again, genetic testing. There are sometimes scenarios where, and again, I don't want to step on Caroline's feet too much in terms of what she's going to talk about, but when we do IVF, we create embryos in the lab. This little time-lapse video I'll play while I'm talking, but this is a video of an embryo developing in the lab. And one big benefit of IVF over IUIs is, since we have the embryo in the lab, we actually are capable of performing a biopsy in more advanced embryos called blastocysts, which the embryo is getting to be a blastocyst right there in that video. So a blastocyst is an embryo that's typically 5 to 6 days post-fertilization. And you can see there in the video, the blastocyst is hundreds of cells, and we can actually perform a biopsy or take a few little cells from the external layer of the embryo called the trophectoderm. And there's different types of genetic testing that can be performed on embryos in the lab. So one example would be, if you have an identified donor where the egg source and the donor both carry the same genetic condition, we could actually test for that genetic condition in the embryo. There's also genetic testing to look at the chromosome status of the embryo that can be done. And I think that probably leads me into the genetic testing slide. So let me check. It seems like a good time, Caroline, for you to talk about genetic testing, since I'm at that point, and then I'll just go back a couple of slides and finish up.
That makes sense. That makes sense. So we have a couple different time options of when we can do genetic testing during treatment. Kind of to start everything is called carrier screening. So that's at the preconception point. So carrier screening, for the most part, is looking for nowadays hundreds of childhood onset conditions. For the majority of those conditions, they are conditions where both the egg source and the sperm source have to carry the same condition for there to be a risk. So kind of like flashback to grade 12 biology with the Punnett squares. If both individuals carry a recessive condition, there's going to be a 1 in 4 chance that they both pass it on at the same time if they carry the same condition. So that's not all of the conditions screened for on carrier screening, but that's a good portion of them. Some of them, there's only a risk if the egg source carries the condition. But this is kind of our first step of figuring out which donor is a good fit for someone. So a lot of the big banks nowadays, you're able to search donors for the conditions that you were found to carry. So almost everyone is a carrier of a couple conditions. And for the most part, we never know until we do carrier screen. Like, we don't have symptoms of those things or a family history. So most of the big banks nowadays, while searching for a donor, you can type in like, only show me donors that were negative for let's say the 2 or 3 things that you were found to carry. So that's a nice option now. So that's carrier screening kind of before we make embryos, and then going into embryos once they get to that little blastocyst stage where we have that outside layer and the inside layer. We take those few cells from the outside layer, so we're not poking around the center and hurting what's going to go on to make the fetus. But kind of the standard test that I would say a good portion of patients do, it's called PGTA, so pre-implantation genetic testing for aneuploidy. So what we're looking for and hoping for are 46 chromosomes. So the packages our DNA comes into. So we're hoping for 46, no more, no less, no extra missing chunks. That does tell us sex, male or female, if you want to know at that point, or it can be hidden. But for the most part, PGTA, it's looking to select the embryo that has the best chance to go on to be successful. So a lot of the changes that we can see on PGTA, there's really nothing that comes from the egg source or the sperm source truly. It's more so like a sporadic error in that egg or sperm, maybe a reason why someone wouldn't have a pregnancy 1 month, or maybe an early loss. So that's PGTA testing. So of course we can only do that with IVF and not IUI, though of course there is still prenatal testing available. And then PGTM, that's when we're going in and trying to test the embryos for a single gene condition. So PGTM, it does take some time to develop, even in 2025. So usually it does take a couple months. So if someone knows that there's a genetic condition that they themselves have, or maybe they know that the egg source carries the same genetic condition as the sperm source, if we know there's something to test for, give yourself a nice amount of time to come set up that test, because it can take months to do. It's a personalized little probe, just for you, just for the person. So if we know, say, the egg source carries a condition, a genetic condition that they know that they have, and they want to test their embryos, they go and make a little personalized probe to kind of track that variant and the chunk of DNA around it. So of course, PGTM, it's great testing, but we need to know what we're looking for to go and make that test. We can't just kind of test the embryo for conditions that we don't know about. And then of course, genetic counselors are there to help with donor selection. So some of the donors you find online, they've already been screened against ASRM guidelines. They're compliant. They're donors that someone has already taken a look at to make sure that they're low risk. Whereas other donors, maybe through an agency, their profiles are just kind of put online, and no one is there kind of going through and making sure that they meet guidelines. And there's something that we would recommend to like our loved ones if they were selecting a donor. So genetic counselors are there to help you go through the carrier screening portion and make sure the conditions that person number 1 carries, person number 2 is negative for, all of that, and then to kind of just help with picking which of many donors someone wants to proceed with.
Caroline, could you speak to just more clearly the differences between if you're choosing if you're going IUI versus IVF, and what genetic tests are available depending on the route?
So the preconception carrier screening is available to everyone. And then for PGT, the embryo testing, that's only through IVF. So we need to make the embryos in the laboratory to be able to take that biopsy. If someone is doing IUI, they can still, of course, do genetic testing. It's just later on. So it's during an established pregnancy. So prenatal diagnostic testing, it's available to anyone who's done IUI or IVF, but it's once a pregnancy is already continuing on towards the end of the first trimester. There's both blood tests and then diagnostic testing available to the person who's carrying the pregnancy. So some of them are, just a blood draw, ultrasound, whereas others could be like the CVS or amniocentesis, where they put a thin needle through the belly and they take a little bit of the pregnancy, and then they can do all of the genetic testing that we had available if someone did IVF, like the PGT, and it can look in even finer detail.
Thank you.
Awesome. Thanks, Caroline. Let me go back just a couple of slides to finish up our discussion of options with donor sperm. So I guess just to piggyback from a pure sort of efficacy, how likely is it to work kind of standpoint, if we're looking at IUI versus IVF, the odds of getting pregnant when we do an insemination around ovulation are going to be dependent again on age. I know I keep going back to harping about age, but it is really the best predictive factor in terms of like likelihood for pregnancy. For someone who may be doing an IUI under 35, the odds of getting pregnant in a given cycle may be in the ballpark of about 15 to 18%. And that's just because human reproduction, we're just not that, we're not very efficient reproducers if you compare us to rabbits or something. Even in our most fertile years, the chance of getting pregnant in a given month when we release one egg and it's exposed to sperm at the right time is about 25%. That's kind of the very best odds for pregnancy, and it kind of goes down from there. With IVF, because we're creating the embryo in the lab and we can do that PGTA testing that Caroline was talking about and assess the chromosome status of the embryo, basically through probably millions of transfers that have been done at this point by placing a genetically tested normal blastocyst into a healthy uterus. We know that the general chance for implantation in a live birth in that scenario is typically around 60 to 65%. So because IVF is certainly more involved, but sometimes, if IUIs either haven't worked or for older ages, it still can provide a better odds for pregnancy because we're doing so much in terms of taking the eggs out, creating the embryos in the lab, doing that testing to understand if there's a chromosome abnormality. And one of the main predictor of how, if you were to do IVF, how many chromosomally normal embryos you may be able to create, again, will be very influenced by age. So when we're biopsying embryos created from eggs that are under 35, generally majority, 70% will be chromosomally normal. Versus if we're creating embryos from eggs that are 41, notably less than half of them, less than 50% are going to be normal. So it's very much, again, part of the reason fertility declines with advancing egg age is because of this egg quality decline that we see. So, but anyways, I'm just going to finish up here. So again, care pathways, if you are in a relationship where you both have a uterus and, potentially both, produce healthy eggs, how do you kind of decide? There's no right or wrong answer here. Most patients I see generally have a sense of like, okay, this person wants to carry and have a child with their eggs, and potentially their partner doesn't, or sometimes they both do. So it really all dependent on like what you ideally desire. We often will start with baseline fertility testing so we can look at egg reserve, different fertility parameters, and again, age. Typically, for someone who still would like to have a child with their eggs, if one partner is older, then oftentimes we may focus there first, because the sooner we either help that person get pregnant with an insemination or do an egg retrieval and create embryos, the better odds for pregnancy we'll have. So again, age is kind of the most important determining factor. But it really just depends, obviously, on personal goals and timing. And at the end of the day, it's generally the thing that limits the reproductive window for those of us who produce eggs is the quality of our eggs, more so than the health or age of the uterus specifically. The uterus doesn't really age in the same way that the eggs do. So for someone who's, let's say, 45 years old, it's very difficult at that age to create a chromosomally normal embryo from a 45-year-old egg, just based on lots of experience and data over the last several decades. But for somebody who's otherwise healthy, no major medical issues, healthy uterus, no chronic issues like hypertension or diabetes, oftentimes people can still carry children into their mid to late 40s and beyond without a lot of complications, so long as the embryo that we're putting in is chromosomally normal and healthy. And so that's something I think to consider too. Sometimes someone may be in a partnership where their partner is going to produce embryos with their eggs, but the person who's going to carry may be in their 40s already. It's not so much the age you are when you become pregnant. Obviously, there are some risks that increase as you are older if you're looking to get pregnant. But if you're generally healthy going into pregnancy, people can typically carry pregnancies at much later ages compared to being able to produce a healthy embryo. So it's really, again, kind of the age of the egg that we're always the most interested in, and trying to either freeze eggs or freeze embryos or do something to optimize egg, creating a healthy embryo at the optimal time. Okay. Just a quick note here about, we do see a lot of people who are interested in becoming single parents by choice at Spring too. And a lot of times, a lot of what I've discussed already is kind of the same pathway we'd follow. But again, we'd like to meet for people who are looking at becoming a single parent by choice, meet with you, understand your medical history, understand your goals, understand the time frame that you might be looking at. If you're thinking that it may be something in the future, we can talk about both egg freezing and embryo freezing as ways to preserve fertility for the future. And again, the donor options really can be tailored. There's so many different ways we create families nowadays, and we see people who need sperm donors, people who need egg donors, people who use embryo donation from another family who created embryos and have excess, and now they're donating them to someone else. Gestational carriers. We really do all of these things pretty regularly at Spring, and so we can talk through all the different options based on what your specific scenario is. And we also have wonderful therapists who work here at Spring too, who can provide both emotional support and counseling. And also, I'll make a plug for, we also have support groups that our therapists run. We do have a single parent by choice support group. And so if it's something that you're looking at, I think it's a really nice adjunct to join that support group and be with other people who are, kind of going through the similar experience to have support. Okay, we already talked about the genetics here. Just gonna finish up here. I want to turn the floor over to allow people to ask questions. We're just gonna talk a little bit about fertility preservation, especially for people who may be looking to start gender affirming hormone therapy. Gender affirming care does include education about fertility preservation and family building options, and making the choice to preserve fertility before beginning gender affirming hormone therapy isn't a matter of deciding right in this moment that you want to have a biologic child one day. It's just about trying to give yourself that option to make the decision that's right for you in the future. And so we also, for individuals who may be seeking to start testosterone for gender affirming care, there's the option to both freeze eggs and freeze embryos, depending on, again, to freeze an embryo, we'd need a sperm source. But if you have a partner that produces sperm or planning to use a sperm donor, embryo cryopreservation would be an option. And then there's also the option of ovarian tissue cryopreservation. That actually involves having a surgery to remove a piece of or the entire ovary and then freezing it in pieces. There's lots and lots and lots of eggs within ovarian tissue. And the way that ovarian tissue has primarily been utilized to date is actually by transplanting it back, which may not, for someone who's starting testosterone, may not be something that we want to consider in the future. But there's a lot of ongoing research about trying to grow eggs and the house. The follicle is basically an egg, and then support cells around the egg that help it grow. And every egg in the ovarian tissue is already in a follicle. There's a lot of ongoing research about trying to grow those follicles outside the body to produce a mature egg and be able to do IVF with. And so that's still in process. There's still a lot of research going on about optimizing our capacity to do that. And then for individuals who may be seeking to start estrogen therapy, sperm cryopreservation is very standard fertility preservation technology. We've been doing it for decades and decades now. Sperm is like the first reproductive tissue we were ever able to freeze successfully. And then again, for people who may be looking to start at a younger age, if sperm production is not hasn't started yet, as someone who might have not gone through puberty yet, then testicular tissue cryopreservation, again, is also something that's being looked at, similar to ovarian tissue preservation, where you take out a piece of the testicle, which has stem cells, spermatogonial stem cells in that tissue that is capable of producing sperm. Again, that's still considered to be an experimental protocol, but there's a lot of people working on being able to optimize getting sperm from testicular tissue, if that's a better route based on somebody's age. So, okay, I think that's all I have. So I'm going to turn it over to anybody who has questions, see for either myself or Caroline. But thanks for having us today.
Thank you. Thank you both for being here. We've got a fair amount of questions and I think 15 minutes to answer. So if you have any more, put it in the Q&A, please. Nikki asked if you can share anything you know about California law SB 729, which is supposed to go into effect next year, which requires many health insurance plans to cover fertility services, including IVF for queer families. I know you are more on the patient-facing side of things, but if you have any information about what insurances Spring takes and what that will look like and how that might change with this new law.
Yeah. Yeah, it certainly should, I think, open up access quite a lot because I know that's obviously one of the biggest barriers to fertility treatment. Sometimes it's just the cost, and that's often not covered by insurance. So I don't know if I could speak to the exact details of the law, but it is going into effect. It actually, I think, went into effect earlier this year, but it doesn't really affect people's until they go through open enrollment and have their next plan. So for most people, they're doing an open enrollment now, and it will go into effect in January. We currently Spring is in network with Cigna, but I know that we are in conversation with other other insurance companies too to expand that coverage. So stay tuned. Yeah, sorry I don't have more specifics about that, but I know we're actually kind of a work in process for us right now too to expand the insurance networks we're in network with to provide better coverage.
And I will say we have a lot of community members that have worked with Spring, get coverage through Progeny is one. And if you have more insurance questions, reach out to me. Someone compiled like a list of hacks for getting fertility care covered. And so that's a resource that I can share. Does Spring complete their own mental health consults for intended parents, or do you refer out to ASRM providers?
We complete them here. Yeah, we actually have a couple of therapists who work at Spring who will do those consults. So yeah.
Cool. Thanks, Jessica, for asking. We have a fair amount of questions on sperm and also directed donors and kind of the logistics of using directed donors. Well, so I'll just start. We have a question about if sperm is affected by age the same ways that eggs are and how you'd respond.
That's a good question. And yes, sperm is affected by age. So someone producing sperm that's coming from someone who's 45 is not the same quality as sperm coming from someone who's 25. But it's not the window of sperm. The main difference is basically that for people who produce sperm, in the testicle, there are what are called spermatogonial stem cells, and they make sperm throughout the lifetime. So there's not like a menopause or like there's not a time where sperm production is just going to shut off. So people who produce sperm can father pregnancies into their 60s 70s and beyond, as I'm sure whereas for people who produce eggs, it's really difficult beyond the early 40s to conceive just because that quality of the egg is so time and so age dependent. But that being said, we do know that advanced age of a sperm donor is associated with lower quality sperm, and it's also there's associations with a higher incidence of like autosomal dominant conditions, and also there's a higher association with like things like autism and schizophrenia. So looking at the age of the sperm donor is still something to definitely look at, and younger sperm is generally associated with better outcomes. So
Thank you. Corinne, who's a CNM, said they were under the impression that known donations still need to be quarantined and tested per FDA regulations. And then we have another question from a member who's a lawyer and a queer parent to be kind of about that process of using a directed known sperm donor at your clinics, kind of the different requirements that need to happen, and if those are spring specific versus FDA regulations. If you could speak to that, I don't know if that's as much your area of expertise.
To some extent, yeah. So in terms of the quarantine question, there's things that the FDA mandates, and then there's also every practice is going to come up with its own sort of, we call it an SOP or a standard operating procedure, the way that and so we always have to follow, at the very least, we have to follow the FDA regulations. Some practices might make their SOP even more stringent than what the FDA requires. And so for the question of quarantine, the FDA doesn't mandate a 6-month quarantine for an identified donor. They do mandate it for a non-identified donor. And so that's how we do follow those FDA guidelines at spring. Yeah, but so it is possible you might, go to another fertility practice, whereas I have heard, I know in some other states and other places, I've seen that they sometimes will mandate a 6-month quarantine regardless of whether it's identified or not identified. So it depends a little bit. That's usually a practice specific issue. And then what was the other part of it? Like using a
Yeah.
identified sperm donor in terms of the legal.
In terms of the legal and like the multiple psychological consultations, I know that sometimes members have kind of been like, I've thought about this a lot, and it's frustrating to have to go through extra barriers that often take more time. And so just curious if you could speak to
Yeah.
just kind of like balancing those FDA legal
Yeah.
recommendations and patient support and all of that.
Um, yeah, I mean, I guess with respect to we wouldn't require for an identified donor the quarantine, and like I said, other places might, but we do have intended parents and their identified donor meet with a reproductive therapist, typically individually and then as a group, just to make sure, again, everyone's sort of on the same page about future relationship, how that might look, and things like that. Usually they can do it pretty quickly and try to do it very, in a quick time frame. So it's not something that would take a long time to complete. And then in terms of a legal contract, typically we would want intended parents to have a legal contract in place with their donor. Just again, that just really specifies like intention for parenthood and I think the status of a donor versus like a parent. So we don't. We have reproductive lawyers that we refer out to, and they're very, very used to making these contracts. So usually I don't find that it usually creates a huge barrier to get started. For someone who's motivated, we can typically kind of do this testing fairly quickly and be moving into treatment fairly quickly in terms of screening the donor and getting that legal agreement in place. So, yeah.
We have so many more questions, you all. We may not be able to answer all of them, but we will try our best. And I know you spoke to fertility preservation before starting gender affirming hormone therapy. We have a question specifically about working with people who are going off of HRT in preparation for family building, if you have anything to share about that.
Specifically with going off testosterone.
The person didn't specify, but
Okay.
maybe you could speak to going off
Yeah.
testosterone. Yeah.
It's a good, I've worked with a lot of people who are on testosterone who have come off to undergo either egg freezing or undergo IVF. And generally, in my experience, having been on testosterone doesn't necessarily make it harder. Like usually we can very successfully do IVF or egg freezing. I know that, and there's definitely a look, there's centers that are looking right now actively at like whether it's even necessary to come off testosterone. Some have actually done cycles where people just take testosterone throughout the stimulation and seem to have adequate outcome. So I think that the question people are looking at is like, we don't really have long-term data about being on testosterone during stimulation and if that has any impact on the health of the eggs, but I think more and more will start to have more information about that. So, but yeah, it's oftentimes it may not even be. I think we're getting to a point where you might not even need to come off testosterone to do a stimulation any longer. So,
That's so cool.
yeah,
We have a member who's doing that right now, and
yeah. For some people, it's just a no-go. They're like, I can't, I really can't
yeah.
come off. And I think, we'd certainly rather still try a stimulation, freeze some eggs or make some embryos. And I think, like I said, I think in the not too distant future, we're gonna have much better data about that. And I know I think you have a talk about what's coming down the pipeline, so maybe they can speak to that more too.
Yes, yes. Our next session is with Dr. Brent, who has done a ton of very specific research on LGBTQ family building. And so we're going to dive more in depth about those
Yeah.
ones. Um, okay, we have a question about the safety measures that you have in place to ensure that the right embryo is implanted and like what you consider best practice for that piece.
Good question. You will find that we basically do like a million identity checks, but actually, as we speak, we're in the process of implementing a new system, like a barcode system. So when you come in, like if you were to undergo an egg retrieval and do IVF, everything is going to be labeled with a barcode that's uniquely attached to you, and that every time anything is ever done with those eggs, we're doing a retrieval, we're going to scan it. It's going to be matched up to this barcode, and in the freezer, it's going to be you'll have a barcode that labels your eggs or embryos. And so it's kind of that, I think that's sort of becoming the standard that we're implementing right now to really ensure that there's never some sort of mix up between people's embryos.
Right.
Yeah.
This is a great question, and it's really something, we often are working with people who are trying at home, and then sometimes they need to
Yep.
go into the clinic, and making that decision is tricky. This person asked, does the risk of twin pregnancy increase for pregnant people age 35 plus using Clomid or letrozole? Or is that only true for younger people or people with no fertility issues? How do you weigh the risk of twin pregnancy against the benefits of using medications to increase fertility?
Yeah. Good question. If we use Clomid or letrozole for everybody, no matter what your age, it increases the risk of multiple. So it's not like it's just unique to people who are under 35. The risk is higher if you're under 35, because you're more likely to release two healthy eggs and have twins with medication, which is why we wouldn't typically, unless there's some extenuating circumstance, start with medication for younger patients doing IUIs. But yeah, if you're 37 or 38 and using those medications, if compared to if we didn't, there's still a higher chance that you could have a multiple pregnancy. And so usually before I ever start anyone on medication, I usually like to have that conversation. It's not always the first thing we do, but it's something we might consider adding on. If you've done a few rounds of IUI, it hasn't worked yet, and sometimes like kind of the next level we might go up to, especially for people who might be in their later 30s or beyond. So
Similarly, you've shared some statistics about success rates of IUI, and we had a question about I mean, it's so hard to include queer people because we don't know queer people who don't have access to sperm in their relationship or their lives because we don't necessarily know who is
yeah,
medically infertile and who is socially infertile.
yeah.
Do you have any research on or statistics about kind of how to make that decision, or do you kind of just go by age because that's the best information that we have for this population?
It's a good question. I mean, the 15 to 18% per IUI under 35 I quoted is typically used from people who are using a sperm donor and don't necessarily have a history of infertility specifically. But it's true. I mean, a lot of the data comes from heterosexual couples who have a history of infertility, and so it's sometimes harder to extrapolate that. I tend to find, I mean, in terms of is a question like do IUI versus do IVF right away sort of decision making, or when to go to IVF?
Yeah, yeah, sort of like how do you counsel people on that? How to know if
Mhm.
you're socially infertile, which is a term that I hate, or medically infertile?
Gotcha. Yeah. Well, again, it typically, like in studies that look at just general fertility, generally speaking, if there's no subfertility issue, usually we'll see a pregnancy conceived within six exposures to sperm. So if someone's done 6 well-timed IUIs, now I start to have a concern. Okay, and I think maybe there is some medical infertility here, not just you don't have access to sperm. So that's it. I mean, that's one of the things I would look at is just how many rounds of IUI have we done? How many exposures to sperm have you had where we didn't have a pregnancy conceived? But it's nowadays, I feel like there's so many different factors that go into it. Sometimes people who may want, sometimes for someone who may be, let's say 36, 37, really wants 2 kids with their eggs. One of the other benefits of IVF that I didn't really mention before is that we often, for people who may want more than one child, we're often trying to not just create an embryo to help you have a child right now, but create some embryos so we have some frozen for a future child. And so that weighs into it a lot too. I think for someone who just wants one child, I'm more likely to try IUIs longer because if we can get that to work, obviously we've saved you from having to do IVF. But if you're on the, older side of 35 and you think you want more than one child, with your eggs, then doing IVF sooner is often something we look at, just also because we can take advantage of that embryo banking benefit of IVF over IUI. So,
Yeah. Awesome. Thank you both so much for being here. Thank you everybody for your questions. I know we didn't get to everything. You can send me an email and I can follow up any remaining questions. We're gonna close up this session. Our next one, which starts in 14 minutes, is with Dr. Brent, who's a reproductive endocrinologist, who really dives into like LGBTQ fertility research. And you will be able to get a lot of remaining questions answered by them. But Serena and Caroline, thank you so much for being here. I know that, yeah, it's so nice that we're close by, and thanks for the work you do to support our community.
absolutely. Yeah. And feel free if you want, I'm happy to answer their questions via email too. So if you want to forward anything to me, I'm happy to answer. So,
Thank you. Yeah, so just send me your questions and we'll get you answers for them.
yeah, cool.
Okay, thank you both.
Absolutely.
Bye.
Bye.